Ladies and gentlemen, dear friends, dear colleagues, welcome at this webinar to present one of the authors of our paper recently published on GREM. I remind you, this is the new open access journal of the International Society of Gynecological and Reproductive Endocrinology. It is an open access journal every 3 months, and we will have this afternoon the pleasure to discuss with an author of this paper, a discussion on bone metabolic and anthropometric changes in very young women with premature ovarian insufficiency or complete androgen insensitivity syndrome with removed gonads using oral estradiol valerate, transdermal estradiol, or ethinylestradiol, a pilot study. The first author of this paper is Giulia Gava. She is an MD, PhD gynecologist, a research fellow at University of Bologna, Department of Medical and Surgical Science, working in gynecology and physiopathology of Human Reproduction Unit at Sant'Orsola Malpighi Hospital. Her research interest is aimed in particular at gynecological endocrinology, which is our topic, from adolescence to menopause, female and male contraception, and pelvic floor dysfunction. Giulia, you have now the microphone. I invite all of you to send us questions, and Dr. Gava, she will answer at the end of her presentation, and I will chair the question and answer session. Then thank you to all of you for being with us. Giulia, it's your time. Thank you.
Thank you, Professor Genazzani, and good afternoon to everyone. So, first of all, I have no financial disclosure of this relation. And first of all, I want you to introduce these conditions. The complete androgen insensitivity syndrome is a quite rare condition with an estimated incidence of 1 to 5 for 100,000 births. It is a 46XY DSD, and it is caused by the loss of function mutation in the gene of the androgen receptor. So we have a female phenotype, but with a normal secreting testis and a complete androgen resistance in all androgen-dependent tissue. So until puberty for these women, we have a normal secretion of testosterone. Thereafter, there can be a little bit of impairment of this secretion. But for the majority of patients, because of the cancer risk, in the last decades, they have undergone gonadectomy in very young ages. And in the last 20 years, it should be considered that the majority of these patients undergone gonadectomy at very young age, so 1, 2 years old, or before puberty anyway. However, now it is known that cancer risk in this child is very rare. It is about less than 3%, but it increases over time, ranging to 33% over 30 years of age. In these women, we have a concern regarding bone health. This is because we know that androgens and estrogens plays a big role in the development of bone mass acquisition, maintenance, and also about bone dysmorphism between male and female. In a case women, we have a production of testosterone that is with quite normal levels, and we know that in these patients, testosterone acts like a hormone, but also especially like a prohormone, as it can be aromatized to this 17-beta estradiol, acting on osteoclast, osteoblasts, and osteocytes. So in adult women with CIS, we know that we have a reduced bone mineral density, mainly after gonadectomy, because of the practice of removing gonads before puberty to prevent cancer sometimes, but also because of an inadequate estrogen supplementation after gonadectomy. But we have also data regarding the impaired androgen receptor action, in particular at the level of the trabecular bone. So osteoporosis is a risk of concern for women living with the CIS, both with gonads or without gonads. Considering patient with complete androgen insensitivity syndrome and intact testis, we have very few data available on BMD. This is because of the practice of early gonadectomy. However, what we can say is that bone health seems to be not so impaired in the majority of the patients. But as you can see here, however, at the level of the lumbar spine, we have a tendency towards reduced BMD values, while at the femoral neck, we have good levels of BMD. This is because at the level of the trabecular bone in the spine, osteoblasts and osteocytes are a target cell for the androgen receptor mediated action, and we can hypothesize that the trabecular bone in this patient is particularly sensible to the impairment of the androgen receptor signaling. However, the biggest problem for these women is when we have removed gonads. As you can see in this summarizing table from Bertelloni, you can see how literature demonstrates that somehow in every study we have an impairment of the lumbar BMD and a little impairment of the femoral neck BMD. But you can see from this table how much data are scarce. You can see here article with 1 patient, 4 patients, 7 patients, so little numbers. And you can see also how much variability there is regarding the therapy administered to those patients and the compliance to the therapy. So it's quite difficult up to now to well understand the effects of hormones, estrogen, and then we will see also androgens in these patients. We recently published this article reporting bone health in 32 CAIS patients. You can see here with a mean age of 35 years. All patients were gonadectomized at the mean age of 12. And as you can see, we matched them with healthy or with normal karyotype patients of the same age and same BMD. And as you can see, the prevalence of impairment in zeta score and T-score, both in the lumbar and femoral sites, are more prevalent in the CAS patients. And you can also see how BMD is lower in the complete androgen sensitivity syndrome patients. And as reported here, the prevalence of vertebral osteoporosis was so far higher in the CAS group compared to the acupuncture group. You can see here a node ratio of 9.7, so big one. And also osteopenia at the vertebral site was more prevalent in the group of CAS patients with a node ratio of 3.9. Considering the femoral site, also in people with removed gonads, the situation isn't so bad. So you can see as the femoral osteopenia is a lot more prevalent, but we have not a big prevalence of femoral osteoporosis at this young age. It should be remembered the young age of these patients. So summarizing, in the CIS patient, we know there is a problem of bone health impairment, both in gonadectomized patients, but also in those with gonads in situ. And we will see how much therapy can help in these patients. Coming to the next topic, premature ovarian insufficiency or POI are quite similar patients in the regard of the bone health. Just to remember, it is a syndrome characterized by the loss of ovarian function before the age of 30. It is characterized by the presence of oligomenorrhea or more frequently amenorrhea, and by laboratoristic side we have an hypergonadotropic hypoestrogenism. The prevalence was believed to be around 1%, but recent meta-analysis reported an higher incidence, about 3.7%. Just a few words to talk about the ethopathogenetic causes of POI. We all know that we can have chromosomal or genetic defects accounting for 25% of POI. Considering chromosomal defects, most frequent are Turner syndrome or Fragile X syndrome, but we can also have autosomal defects or isolated disease. Otherwise, secondary amenorrhea is more frequently associated with other conditions than chromosomal or genetic defects, like metabolic condition, iatrogenic condition like surgery, chemo, or radiotherapy, or idiopathic condition in the 60% of cases. When considering women with POI, short-term effects are important to the quality of life of these patients because of vasomotor symptoms, vaginal dryness, or mood swings. But what we have to remember always are the long-term effects. They can be devastating to those patients with cognitive dysfunction, problems of memory, concentration, increased risk of dementia, but also the important burden of the cardiovascular health that can be impaired in terms of endothelial function, but also metabolic alteration predisposing to increased cardiovascular mortality. We know that also other sites can be impacted. We will see bones and urogenital symptoms. But we know from studies of ROCA that women with an estrogen deficit before the age of 45 have an increased risk of death, twice the risk of death than the referent women. We know that each year of delay of menopause is 22% of risk less of death for these women. So each year counts, and the adequate treatment, hormonal treatment, is important to give those women a normal quality of life and a normal life expectancy. Going to the topic of bone health, osteoporosis is a key concern for women with a POI, with an estimated prevalence of osteoporosis ranging from 8 to 27%, depending on definition of osteoporosis and on definition of POI that has changed through the years. However, what we should always remember in consideration of bone health is well summarized in this white paper of the International Menopause Society of the last year. And as you can see here, what we should consider is not only the diagnosis of POI, but it's also the condition associated with it. So we have to ask the patient when the menses started to be irregular, because if this timing was corresponding to the time of peak bone mass accrual, is very detrimental to bone health. If how much has been long the POI before of diagnosis and the treatment start, and if there are other conditions that can impair the bone health by itself, so like malabsorption or poor balance, or like collagen deficit that can be associated to specific genetic disease. For these patients, all patients diagnosed with POI should be studied with the anthropometric scan at the time of diagnosis. And we can also consider to associate blood and urine tests, like by evaluation of electrolyte, calcium, 25-deoxyvitamin D on blood, and also thyroid function that is very relevant to unhealthy bone. Considering treatment, every woman with a POI should be offered an adequate estrogen replacement therapy. at the time of diagnosis, and unless there is a big contraindication. We should also provide patients with knowledge about the importance to continue this treatment until the time of natural menopause, and the importance to be adherent to the treatment. It is known that in this young patient, adherence to treatment are not so high sometimes. So knowledge we give the patient is maybe one of the most useful tools we can give them. Otherwise, other than hormonal treatment, also healthy lifestyle regarding bone health is important to be provided to these patients. Considering patients with normal BMD, we should evaluate the BMD through the densitometric scan. Sorry for the noise. For the densitometric scan in the future. Depending on the health status of the bone at the time of the first monitoring. However, even if we have seen that hormonal treatment is mandatory for POI patients, there is still a lot of confusion regarding the preference of the type of therapy we should propose to those patients. And as you can see in this survey conducted in the UK, you can see how some gynecologists still believe that maybe the best therapy is the oral contraceptive for patients with young patients with POI. So we should ask, why should we use a contraceptive pill as a hormone replacement for women with POI? The oral combined pill seems to be more socially acceptable, maybe for young women with POI, and also to reduce the stigma associated with menopause. Furthermore, it should be considered that it is maybe more accessible. In some countries, it is provided for free, so this should also be considered. And it provides contraception, unlikely the hormonal replacement therapy for those women with young age and a recent onset of POI. Risk of pregnancy should be considered, even if the major trouble is the infertility. We should also consider those who don't want a pregnancy. However, considering literature regarding the optimal therapy for women with the POI, very young women with POI, we should always remember that the majority of data from literature come from study considering older women with menopause and derives this data to young people with the POI. So I'm giving you now some data regarding studies specifically designed for young women with POI, and we will see that there are very few data and very little studies. Starting from the study of Gutman almost 20 years ago, he reported data from 17 POI with the Thurman syndrome, and as you can see, they compared a relatively low dose of oral conjugated estrogens compared with 30 micrograms of ethinylestradiol. And they told us that after 6 months, the hormonal treatment led to lower bone turnover. So the first data came out for this population, suggesting us that the hormonal treatment, hormonal replacement treatment was superior to the ethinylestradiol in preserving the bone health. Going on, the first of two randomized control trial we have now is from Crofton in 2010. He evaluated 34 women with a POI, randomized to two types of treatment. The one he defined more physiological one was a transdermal estradiol, 100 and 150 micrograms compared with what you called the standard hormone replacement treatment, that was the oral ethinylestradiol, 30 micrograms. As you can see here, in particular at the level of the lumbar spine, that, as we told before, is the site where the trabecular bone is more present, and it is the site where hormones are more prone to act. You can see here that the transdermal estradiol was able to improve the bone mineral density more than the therapy with oral ethinylestradiol. At the femoral neck site, otherwise, you can see here there is also a small increase in BMD. However, the result between the transdermal estradiol and the ethinylestradiol is pretty similar. Considering bone formation markers, they were more increased in the transdermal estradiol, while in the ethinylestradiol they were decreased. And both treatments suppressed the bone resorption marker, the cross labs. So also here, transdermal estradiol was doing better than the oral ethinylestradiol. In the last study, randomized control study on this topic is from Cartwright in 2016. He enrolled 59 patients with POI of different causes with a mean age of 40 years, so a little bit older. They were treated with oral estradiol, 2 milligrams, and compared with those treated with oral ethinylestradiol, 30 micrograms, both combined with a progestin, the same one to be more without bias. And you can see here only 36 women completed the trial. You can see the majority that maintained the therapy, they were the contraceptive one, and then the oral replacement therapy, and then the no treatment group. And as you can see here, the comparison is between those three groups, and the best results we can talk about is about the lumbar spine site, as before told. And as you can see in the green line is the hormonal replacement treatment group. You can see we have an increase in BMD over 24 months, 2 years of treatment. Otherwise, oral contraceptive maintained with a big standard deviation, but maintained the BMD. While in the blue line, we have the no treatment group, there is a big fall of the bone density. Considering the femoral neck, we have a similar result, but a little bit less clear because of the less response to the hormonal treatment of the bone of the neck. And as you can see here, we have also in this site decline of BMD in the no treatment group, quite increase in the BMD in the hormonal treatment group, in the hormone replacement group, and a stable level in the oral contraceptive. So also this study confirmed that the hormone replacement therapy was superior. So estradiol, oral estradiol was superior to oral ethinylestradiol in the preservation of bone mineral density. In the last study I found related to this topic is from Gazzara, published in Menopause in the last year. Is an observational study, so maybe the methodological analysis is lower than the randomized control trial that I presented you, and they analyzed a big number of on the cytometric scan of about 119 women with POI with a mean age of 30 years, so quite younger than the previous study. They compared the use of continuous use of oral contraceptive containing 30 micrograms of ethinylestradiol with hormone replacement therapy, low dose or high dose, and also Tibon, but without a good power analysis for other treatments. As you can see here, they reported that low dose hormonal treatment was inferior to the oral contraceptive, but the oral contraceptive was similar to the high dose hormonal treatment. So they concluded that the oral contraceptive can be supported by their data. They concluded that the oral contraceptive can be proposed for the long-term treatment also to the youngest POI. However, I prefer to interpret those results in the term that we have to choose the right dosage of the natural estradiol to give those patients the optimal also benefits and risk of the treatment. We have to consider that those treatments are long-term treatment. So we have to give hormones in the more physiological way possible, minimizing risks. So as we discussed, also the white paper of the International Menopause Society concluded that from those randomized controlled trial, we should choose the more physiological dose of transdermal estradiol, 150 micrograms by the transdermal route, or 2 milligrams of oral estradiols, because they may be superior to the 30 micrograms of ethinylestradiol. The reason of this superiority should be recognized in the lower impact, hepatic impact of transdermal estradiol if compared with the oral ethinylestradiol. With avoiding the first pass metabolism, transdermal estradiol is similarly also oral estradiol does not suppress insulin-like growth factor 1, that is a bone trophic hormone that is downregulated by ethinylestradiol. Avoiding the first pass, it can also minimize the prothrombotic effect of oral ethinylestradiol, giving a more safe product. And we can also have a less stimulation of sex hormone binding globulin, having more bioavailable estradiol. However, even if those data seems to be quite clear, we have to remember we have very little data, that POI is still quite a rare condition. And even if we have possibility to collect more data on registry, we still need more research on this topic. For this reason, we should also consider that modern COC now are different from the older. So they are continuous, have reduced hormone-free intervals, and some deliver the 70 beta estradiol. So they may be so different from the one delivering ethinylestradiol. For this reason, in the UK, the POISE study, premature ovarian insufficiency study of effectiveness of hormonal therapy is starting, and it should be a 2 or 5 year prospective long-term study collecting data on POI and addressing the possible differences in outcome of therapy between hormonal therapy and COC. Coming to our study recently published on BREM, our study aimed to compare changes in bone, metabolic, and anthropometric parameters in very young women with hypergonadotropic amenorrhea. In our study, we collected data regarding women with premature ovarian insufficiency and women with complete androgen insensitivity syndrome, and analyzed them all together to increase the power of our analysis. We included only CIS with removed gonads to have the perfect model. In this case, we excluded the women with CIS with intact gonads still producing testosterone. So we divided our patients into 4 groups according to the treatment at the time of the enrollment in the study. So as you can see here, we divided them in transdermal estradiol or gel users, or patch, gel or patch users. We have the group of the oral estradiol group, the oral ethinylestradiol group, and the no treatment groups. Those patients were mainly treated in our center or other centers. So we also have a no treatment group that came in our center at the time of the second evaluation of the insufficiency scan, and we give them therapy at the time we first saw them. So as you can see here, we enrolled 40 women. 55% of those were diagnosed with complete androgen insensitivity syndrome, and 45% with premature ovarian insufficiency with different causes. 20% were idiopathic or iatrogenic, and 25% presented with Turner syndrome. The mean age at the time of the first densitometric evaluation of the whole cohort was 23 years. And it is relevant data of this cohort because they are very young, and it is difficult to have data in this young population, as we have seen from previous studies. And we collected them data and analyzed retrospectively the densitometric evaluations. And as you can see here, we enrolled only women with at least 2 densitometric evaluations. And the timing between the 2 densitometric evaluation of our cohort was about 2 years, so 22 months. And there was no significant differences in timing of densitometric evaluation between the 4 groups. Patients reported that hormone treatment were used correctly, and they did not change dosage or molecules during the use. Here are our results. First of all, the most important data is that at the time of the first evaluation, almost the whole cohort of patients presented some impairment of the bone mineral density, and in particular, the lumbar site was the most affected one. Only 5% of patients presented with normal BMD in all bone sites, while 75% presented with osteopenia and 20% with osteoporosis in at least one bone site. In this table, you can see our cohorts subdivided into the 4 groups I told you about. And as you can see, age was quite similar in the 4 groups. They were very young, ranging from 24 years to 20 years. The BMI was similar between the 4 groups, reducing the bias for a different impact on BMD. And rate of smokers was similar also between groups. As you can see here, we evaluated the delta. So we evaluated how much the BMD was changed in 2 years of treatment. And as you can see, there is also by first sight, there is a different impact of the transdermal formulation, that is the first column, and oral estradiol, that is the second one, if compared with the other 2 groups, so oral ethinylestradiol and no treatment group. As you can see, the delta is changing in a positive way in the first 2, so the transdermal one and the oral estradiol, and changing in negative way. So they are in the first 2 groups, they are gaining bone mineral density, and while in the estradiol and no treatment group, they are losing bone mineral density. Similarly, data are data from the femoral site, but also in our study, the biggest impact is on the lumbar site. So from the ANOVA results, we have understand that the lumbar BMD had a significant time treatment interaction effect during the 2 years of treatment. And our post-hoc analysis revealed that we had a significant increase in lumbar BMD in the oral estradiol group, that is the first figure here in the upper part of the slide. When compared with the no treatment, as you can see, there is a reduction in the BMD delta, and in the transdermal estradiol if compared with the no treatment group. So at the level of the spine, what we can say is that both transdermal and oral estradiol are superior to no treatment, and maybe superior also to the ethinylestradiol, even if the standard deviation did not permit to show a significant difference. Considering the femoral BMD variation, also here we detected a significant time treatment interaction effect with an increase in femoral BMD, both in the transdermal estradiol and the oral estradiol group when compared with the no treatment group and the ethinylestradiol group. Considering metabolic data and anthropometric data, we had an healthy BMI for all groups, and it did not change significantly over the time in the 4 groups. And considering metabolic data, we have also a good maintenance of healthy parameters throughout the observation of the patients. So certainly we have to acknowledge some limitation of our study because it's a very small pilot study, but we have to consider that POI and CIS are very rare conditions, and this certainly limits the possibility to enroll a lot of people. So this is why also registries are welcomed to increase the power of future studies. Furthermore, we have to consider that we included in our analysis different etiologies of amenorrhea and also different types of treatments, including the presence or less of a progestin associated to estradiol. It's obvious, but in people with CIS, they don't have uterus, so they don't need a progestin, while women with a POI, obviously, yes, if they have a uterus. Furthermore, other than the retrospective natures of our study, it should also be considered that even if each patient had performed the densitometric evaluation with the same machine, the whole cohort of our study did not have the same machine. So we have some limitation that can be addressed in future studies. In conclusion, consistently with previous literature in our cohort of women with POI or CIS, they have an impairment of BMD, of bone health, in particular at the lumbar level. After 2 years of treatment, women that were using oral ethinylestradiol or not receiving any treatment, they show a subtle reduction or no significant change in BMD. And the most important message is that in those very young women with hypergonadotropic hypogonadism, oral estradiol valerate or transdermal estradiol are both associated with greater improvement in bone health if compared with oral ethinylestradiol. So thank you for your attention.
Thank you very much, Giulia, for that beautiful presentation, full of data, full of information. I would like first of all to make a comment. We have received some question, and we will start with the question. And I've seen that in the data that you mentioned from literature, the transdermal treatment was always done with transdermal patches with 100 or 150 micrograms of estradiol per day, while normally the general use is a patch of 50. Then this is something that we have to consider, that probably facing this kind of patients, also the transdermal patch, we have to believe that the total amount of estradiol can have some importance, as you have seen giving orally 2 milligrams of estradiol. What is your comment about that point?
Yes. I totally agree. The dose is the biggest is the biggest topic in these patients. Also because they are very young, so we should consider not to use dosage typical of late menopause or postmenopausal patients, but we have to give those young women what they need to have at the very young age that they are. So certainly literature should in the future, studies in the future should be more focused also on the dosage in young people. So and this is also the biggest problem with this literature is that there is a big heterogeneity in dosage used and molecules and patients. So it is also a limit of our study. I stated that. But you know, in rare population, it's difficult to collect big data, and maybe the most obvious things to do in the past was to use data from the biggest trial from postmenopausal women. But maybe now we cannot more accept them, but we should do more for these young women.
Yes, then we have a question from Anonymous. What contraception you offer these patients? I believe that is speaking about premature ovarian insufficiency. Do you have experience in combining hormonal replacement therapy with estrogen only and IUD?
Yeah, I think it is a very good option because with the 52 micrograms levonorgestrel releasing system, intrauterine system, you can have a good protection of the endometrium, and you can minimize the exposure of the patient to progestin. I believe that it is more used in other countries than in Italy, but like France, I know there's a lot of use of this type of contraception. And it can provide both contraception, but it can use also when we don't really need a contraception for that person, because we can offer a good protection of the endometrium without harming so much the whole body with the progestin.
Yes, and then is now another question: is women with the POI or CAS are candidates for long-term hormonal treatment and are often worried about breast cancer risk. What can we tell to these women?
This is frequently a matter of concern for these young women, because we told them that they have to do a very, very long-term hormonal treatment, and they believe sometimes that they can have risks similar to those for postmenopausal women. In the reality, there are reports that tell us that the risk of breast cancer is slightly lower in people with the POI, and that is believed because they have less exposure to estrogens through their whole life, and also giving them a long-term therapy with hormones does not increase this risk if compared with the young people of their age at the same time. So we don't have to mix results from postmenopausal women with those with young age with POI and hormonal treatment. And furthermore, we have to always remember people with the POI that not doing hormonal therapy can increase their cardiovascular morbidity, mortality, risk of dementia, cognitive impairment, and also bone health, sexual health. So for sure, pros are more than cons in the choice of long-term therapy. So.
I think it is a problem of the long-term therapy remain always open, and as you believe, we are absolutely in favor of that, but with an appropriate series of control who have to be individualized for the patient. And we have now another question. In young patients with POI or CAS, so which timing of DEXA scan do you suggest? And should we consider also non-hormonal treatment in the case of osteoporosis?
At the time of the first evaluation of POI or CIS patient, we should always perform, for those with the removed gonads, we should always perform a densitometric scan to see how we are starting. Afterwards, if we have a good patient compliant to the treatment and the first densitometric scan is perfect, we can consider to postpone the evaluation in the time. But if we have an impairment of BMD at the first evaluation, after 2 or 3 years, we should do another one. And regarding the use of other treatments, first of all, if we have an osteoporosis that is not treated by the hormonal therapy, first of all, we should ask ourselves if the hormonal treatment is correct for that patient, if the dose is correct, as you were saying before, if the dosage is too low or the route of administration is wrong, we can have osteoporosis even if the patient is taking her pill. So first of all, this is the first consideration. But if we have the right therapy, so maybe the transdermal one with a high dose, but still have osteoporosis, we should perform other evaluation. So we have to address if there are other risk factors for osteoporosis, like dosage of parathormone, addressing the thyroid function or malabsorption. And if still present the osteoporosis, if we have cured the cause, we can ask also the specialist of osteoporosis if we can work together to add other anti-resorptive therapies to our hormonal treatment. In our experience, typically, if the hormonal treatment is good, we have an improving bone health over the years in those compliant with therapy. So it's not very often necessary to add other than hormones.
We have a question also interesting from an anonymous. Do you think these results regarding hormone replacement therapy could be extrapolated to eating disorder patients with prolonged amenorrhea?
Somehow. Also in people with eating disorder, we can have an help from the transdermal route of administration of estrogens because of the eating disorder itself, or because most of all, because of the lower impact of insulin-like factor 1. But in those patients, we have a different condition. So the eating disorder can impact itself the bone health. So even if we have a good estrogen replacement, but we don't have adequate nutrition, adequate fat mass, we won't have a good outcome on bone.
Yes. I think this is a very important point. Also, we have one question now from, I can answer from Catherine Roth. She asked, what do we think about estradiol pills or estetrol pills? As you know, Catherine, we don't have yet, never tested estetrol pills in general practice. We don't have yet in Europe. And I'm sure it will be a very interesting aspect, the evaluation of their bone effects. And then another, Manju Navani, she have made a series of questions. I would like to focus on one. What investigation do you do in cases of POI? And do your patients under 30 have a karyotype?
I went fast on diagnosis because it was not the topic, but yes, young people with POI should always be addressed with the karyotype, first of all. We have also to research for hidden mosaicism for these patients. In very young people with primary amenorrhea, especially the most frequent cause is the chromosomic cause or the genetic cause. So we should do the karyotype. If it is normal, we should discuss with the family also about the patient the possibility to perform other tests, that is the test for the permutation of X fragile syndrome, that is relevant also to other relatives of the patient because the risk of mental retardation in the male relatives. Nowadays, it is not suggested to do genetic testing for autosomal disease or autosomal genes. for all patients, but if we have a specific phenotypical condition or familiar condition, we should also talk with the genetist to address also this topic. Otherwise, in the panel of evaluation, I mentioned it briefly, but also the evaluation of autoimmune associated disorder is important. They maybe are not specifically cause of the POI, but they are certainly associated more frequently than in other people. So we should address periodically the thyroid function and the thyroid autoimmunity, but also the surrenal gland antibodies for evaluation of Addison disorder.
Thank you. And also another interesting question. This is most related to complete androgen insufficiency insensibility syndrome. Some theories support the use of testosterone as a replacement therapy for CAS. What do you think?
Yeah. This is an old question, old topic that
remain always
very,
young.
Yes, that and it's very interesting. And recently there was a paper published by a multi-center group coordinated by Olaf Fjord of Lübeck University that reported a randomized controlled trial comparing testosterone, transdermal testosterone to estradiol, transdermal. And they showed us that side effects and safety were similar between the two products, but it was a short study, so we still don't have data regarding the effects on bone or cardiovascular system. The theory is that testosterone can have also a non-receptor mediated action on tissues. So somebody says that maybe we can have a different action of testosterone than of estradiol. So I think we have to wait more in the future to have more data, but I think there is a possible rationale for this therapy.
Thank you very much. And then now is one anonymous also asking, many women are interested in infertility in POI. And they will not take hormone replacement therapy. There's still a role in doing bone mass density evaluation. I would like to remind to all of you that in POI, the hormone replacement therapy done with estradiol and micronized progesterone is associated with a possible help in spontaneous fertility. It's not an anti-fertility, because also fertility requires good estrogenide and also good endometrium under progesterone stimulation, and this may help spontaneous fertility. I would like to have, Julia, your beliefs about that point.
Yeah. The fear of the patients is always present, and sometimes also patients are focused on fertility when we tell them at a very young age they have a premature ovarian insufficiency. We have to underline them that the hormonal replacement therapy is not contraceptive. So if they ovulate, the therapy cannot harm in any way the possible pregnancy. There are reports that small amounts of estradiol supplementation can also somehow wake up some ovocytes. I can say that. And otherwise, we have to underline today's patients the importance of long-term treatment. Maybe we can also ask the help of a psychologist to communicate the diagnosis. And in this topic, maybe also the change of the name from failure to insufficiency is also a good thing, because it helps us somehow and tell the patient that pregnancy is still not impossible. There is a small amount of resumption of function of POI ovaries.
Thank you. And then also now related to the duration of treatment, how long should hormonal treatment continue for both POI and CIS patients?
Yeah, for the POI patients, almost all literature tell us that we have to continue up to the natural age of menopause, so about 50, 51 years old. Obviously, we have to continue to monitor the patient to assess that there are no big contraindications to the continuation of therapy. And we can also modulate dosage to the age of the patient and changing situation, but we have to continue up to that. After 15 years, we can discuss with the patient from that point for the future. We can also continue with the therapy if the patients agree to do that, and if she has symptoms, we can do that. Considering the CAS patient, maybe the question is not so clear. So we have to continue up to natural menopause, but maybe if we consider that they are people born with testes, and testes
Yes.
does not stop its production of testosterone at 51 years old, so abruptly, like ovaries. So maybe in the future we will come to the knowledge if we should continue or not.
I have an experience, a personal experience with some patients which are over 80s, and they still are continuing the treatment, also because we were following your observation that normally the testis is still functioning until elderly. And then why we have to stop in these patients the estradiol administration if we have make a gonadectomy who completely deplete their gonadal steroids. And then I am more in favor of this, of your second vision, the possibility to follow the patient and to continue until the end of their life.
And after, furthermore, they don't have the uterus, so you can do also only the estrogen therapy, and this is a very, very low risk therapy.
Yes. This is absolutely the way that we are doing with our small group of patients which are continuing to follow us. Then I have another question. What suggestions should we give to patients with hypergonadotrophic hypogonadism to prevent bone loss?
I think the most important key message is that
the point is to patients with hypergonadotrophic. I don't speak about hypergonadotrophic hypogonadism after natural menopause.
Obviously. But I think the suggestion
they're the same, very similar.
The same. No, not the same. For young women, the most important key message is that their bone health is related to the adherence of the therapy. If they stop the therapy, takes it one day yes, one day no, the bone health won't be preserved. Otherwise, health type suggestion can be to have a normal body weight, not to be underweight. This is an important risk for bone density reduction. Have a good intake of calcium and vitamin D. We usually monitor on blood exams the vitamin D levels. If they are not fine, we can supplement them. They should do some sport. Sport is a therapy for bone that can muscle growing, can remodel the bone, and so with the help of estrogens, they can have a synergic action. And they should also try not to smoke or not to drink alcoholic, like they are linked to a reduction in bone health.
Thank you. And then now one question from Bill Quiz-Aga. He asked a young person with POI, what treatment is best, COC or hormone replacement therapy? I would like, I wait your answer. I will probably make a comment.
According to literature, and what I prefer is the hormonal replacement therapy, especially the transdermal one with adequate dosage. That is, but you know, if the patients don't want that type of therapy, what is really important for me for the patient is that she goes home and takes something. So if she prefer the pill because it's the same that her best friend takes, so goes the pill. But some is a good option. better than nothing. But over the time, we should try to reconcile her and try to change the treatment.
Yes, and I would like to add something. The pills are many, but you have to consider that in this group, it's better to avoid ethinylestradiol low dose in any case because it's too low, but also it should be better to give a natural estrogen such as estradiol, valerate, or estradiol, because they are in slightly higher quantities, and these have an effect on the general biology. If we have 1.5 or 2 milligrams of estradiol, this is something. And then in this case, I would like to suggest that you move to this kind of pill if they are available in your country.
Yeah. Also, it's possible to use that pill and to remove the hormone-free interval that is useless for this type of patient, also arming.
Yes.
Yeah.
And also I would like to we have already completed our hour, and we had still we have all the people who participate are all there. And then I would like Julia to ask you a final comment. When we have to face complete androgen insensitivity syndrome, is something who comply also have a lot of open a lot of point for the patients, who I am, what it will be my future, how I can manage my sexuality, if I can have any sexuality. Sometimes we have a genital malformation, the vagina sometimes is very small, and so. And then I would like to ask you about not only the bone or the metabolic impact, but also how to manage the patient and how to face possible local treatments to improve the feminilization of the local genitalia. This is one. Then I will make the second one. Please, I would like to...
First of all, what is important with the CIS patient is a multidisciplinary approach. Usually in center, when people with this diagnosis are treated, we have the gynecologist, the pediatrician, the psychologist, the genetist, also the possibility to do psychological support into the same center. What is also important is the possibility to assess also communities or groups of people with the same condition that can help also with addressing the stress of the diagnosis. And most of all for the CIS people and those with genital malformation in the last decades, they were surgical treated very early, and by the pediatrician, the surgeon, and this maybe was too much, was a mistake, and the association had helped a lot in this way also to try to address the problem of the identity of these people. Regarding the aspect of genitalia, usually the external genitalia in people with the CIS are quite normal, like female phenotype for the external genitalia. It is different from the PIS patient, so those with the partial insensitivity syndrome. But I don't believe that the aspect of the external genitalia is so much important to these people, because what is more important is the mental aspect of their brain, because these androgens during the fetal time have androgenized the brain, and so their sexual identity is not so straightforward. So I won't address only the aspect exterior or aspect of the female genitalia, but also the mental aspect. So we should try before to understand what type of sexuality that patients want and what their identity is.
Thank you, Giulia. Thank you very much. Thank you for your not only a clever scientist, a good scientist, but also a fantastic human person. We bring up to us the image of the problem that we have to face. And then I would like a final comment from you. First of all, thank you for being one author of GRAM. I invite to send again, to follow again,
Thank
and to
you.
send also other contributions.
It was a pleasure.
I
Thank
thank
you.
all group and Professor Merigiola from
Yeah.
which is the leader of your group investigation group. Please, I would like to have your final comment to the importance of this type of investigation in this type of individual.
It is very important because also for the patient itself, because they are quite rare population, especially CIS patients, but also the POI patients. And we need data specific for them, not data derived from other population. And this can also not only improve the health of the patient in the long time, that is very, very much important, but also the relationship between the healthcare provider and the patient itself with a more personalized therapy on the patient itself. So I think this is the most important thing.
Thank you,
Thank
Julia.
you,
Thank
Professor
you again.
Giannazzani.
Thank to all of you.
And thank you to everyone.
Thank to all of you of being with us. And then I remind you that our GREM, Gynecologic and Reproductive Endocrinology and Metabolism, is our open access journal of ISGE. I wait your manuscript, read our articles, and next month we will have, at the end of September, next issue will appear, and the next month in October we will have a presentation of another author. And I would like also to remind all of you that the next year in May, we will have the Congress of the International Society of Gynecological Endocrinology, and which will be in May, 11, 14 of May. It will be an on-site event, also distributed online. I invite all of you of being with us. You can participate on site. You can participate also register online. You will have a fantastic event as it is in the tradition of the International Society of Gynecological Endocrinology Florence Congresses. I thank all of you of being with us and welcome. Have a good time. Take care. Stay safe. Promote vaccination. Julia, thank you. And thank to all of you of being with us. It was a very beautiful session with a very young and nice and fantastic author. Thank you, Julia.
Thank you so much, Professor Giannazzani. Thank you, everyone.